Hi there. So I wanted to talk about vaginoplasties. So this is a virtual consultation to basically talk with you about the process that's involved in setting up a vaginoplasty. So there are components that we want to understand throughout the process. So I want to talk about what to expect preoperatively, so the preparation and the requirements, what you're going to expect intraoperatively, and then postoperative outcomes and potential complications and risks. So during the initial visit, my primary focus is going to be on establishing safety. More than anything else, I want to make sure that you have a very safe outcome. So we'll review your medical intake form and then also look at your medical history. So my goal is to find anything in your medical history that could potentially contribute to poor outcomes, to wound healing issues, to bleeding, to anything that could potentially affect the long-term outcome of your operation. So there are several things that could potentially contribute to poor outcomes. So number one, bleeding. So I'm looking for anything that can contribute to increased chance for bleeding. So certain types of medications, such as NSAIDs, non-steroidal anti-inflammatory medications, such as aspirin, Aleve, ibuprofen. Plavix is another type of medication, Coumadin. So I want to make sure that you're not using those medications around the time of the operation, which can contribute to bleeding. I'm also looking to see if you have a smoking history, so using any tobacco products or nicotine, because that can also very adversely affect wound healing. So I want to make sure that you're not using any of those products around the time of the operation. And then I'm certainly looking for anything that could interact with the general anesthesia. There might be certain types of medications and certain types of medical conditions that can have an adverse effect with the general anesthesia. So I want to review that and make sure that's not going to be an issue when moving forward with the operation. With that, once I've reviewed your medical history, I'll also want to establish that you do have good support in your life. I think more than anything, having good support, social support is going to be important. Vaginoplasty is not only going to create a lot of happy feelings and excitement, but negative feelings may sometimes occur as well. And this is going to be usual for any type of stressor that happens in life. So starting a new job, ending a job, starting a relationship, moving to a new place, those are all stressors. And studies have shown that having good social support around you is definitely going to help you and able to move forward positively when dealing with these stresses. So it's not uncommon to get some degree of postoperative blues or depression when moving forward with an operation, particularly with an operation that's as involved as a vaginoplasty. So having good support from your therapist, from your doctors, from me, from my office staff, is going to be super, super important. So I do want to establish that you do have a good support system in your post-operative recovery. And so once again, if everything looks okay from a medical standpoint, everything looks okay from a social standpoint, then I think it's okay for us to move forward with getting your operation set up. And even in situations where there are particular medical issues or social issues or psychological issues that might be potential impediments, those are certainly not contraindications to moving forward. I want you to be open and honest. So once I know everything that's going on in your medical life, in your psychological life, in your social life, if there are any particular issues, then we will work with you to make sure that we can get those issues resolved and optimized so that we can move forward and be safe. Another very important component of the medical background is your weight. And so I look at what's referred to as the body mass index, which is a combination of both your height and your weight. So it's a formula that basically establishes your health profile, I suppose, in regards to your weight. So studies have shown that if you are overweight or obese, or have what's referred to as a body mass index higher than 35, then you do have a higher chance of developing issues or complications. And reviewing the data among my own patients, I found that if you do have a body mass index higher than 35, it can lead to complications. Higher chance of wound breakdown, higher chance for infections, higher chance for abscesses, higher chance for developing tightening or closing of the vagina. And there's also a higher level of patient dissatisfaction if you're moving forward with the vaginoplasty if you are in an unhealthy weight range. So many of my patients who are overweight or obese, once again, this is not going to be a contraindication to moving forward, but this is going to be something that we're going to work on together. So for many patients, I think what works very well is setting up a date in the future, maybe a year and a half down the line, and then during that time interval, we'll work with you on weight loss. We'll keep checking in with you, making sure that your weight loss is going in a positive direction. And what I found to be very helpful is that if you do have a date that is set for your operation, that is oftentimes a very, very good driving force for you to lead a healthier lifestyle and to work on weight loss. The next step of the process, or another aspect of the preoperative preparation, is hair removal. It's really important to have hair removal from the scrotum and then also from the base of the shaft of the penis, because these are areas that I use to construct the inside of the vagina. And so if you don't have hair removed beforehand, this can lead to hair growth within the vagina, which can lead to issues with infection, with smells, with vaginosis, with vaginitis. So either laser hair removal or electrolysis can be performed preoperatively. And this typically can take up until about 6 months to accomplish. If you do not have a hair removal specialist in your area, or you're not familiar with any hair removal specialists, there's several in our area here in Northern California and throughout California that we do work with, so we can provide a referral so that you can work with them. And hair removal does take a while. It can take up until about 6 months to have complete hair removal, so you do want to start that process early. And if you do know that you're going to move forward with a vaginoplasty, there's no reason why you can't start the hair removal now, because hair removal is obviously permanently, so the earlier you get it done, the earlier you can move forward with a vaginoplasty, and that's going to be one less thing that you have to think about on your checklist as you move forward with this very important operation. And so after a consultation, the next step is going to be a discussion with their scheduler. So she'll reach out to you after the consultation. She'll go through my calendar with you and find a date or potentially several dates that might particularly work. And so then we'll go ahead and put you down in the calendar. I think what's going to be really important before we can truly solidify that date is getting appropriate letters of referral and support. So for majority of insurance companies, we do need a total of 3 letters. We need 2 letters from mental health therapists, and one of them does have to be from an MD or a PhD background or a doctorate background. And then we also need a 3rd letter from your hormone prescriber, basically attesting that you've been on hormones for at least a year. And once again, these are requirements that have been established by the majority of insurance companies. And certainly there's some insurance companies that do have variations, but to be on the safe side, that is the best, I think, protocol to follow to ensure that we have all of the appropriate information before moving forward. Approximately 6 to 8 weeks before the operation, you will receive pre-operative paperwork. And this will delineate, once again, everything that you need to do to prepare for the operation, what to expect intraoperatively, and then all of the post-operative care and supplies that you'll need. So this is something that you'll be able to review beforehand so that you can adequately prepare for the operation. Before the operation, so a few months before the operation, we do contact your insurance company to get appropriate authorization to move forward with the operation. So we do have a very good, strong insurance team that will do everything in its power to make sure we can move forward with your operation. So we want to make sure that the process is easy for you. We want to unload all of that burden from you, and then we do everything that we can from an insurance standpoint to make sure that we get appropriate coverage. If there are any issues, then my team will reach out to you and let you know what needs to be done to be able to move forward in a smooth process. But we found that for the majority of patients, moving forward with vaginoplasty from an insurance standpoint hasn't been terribly difficult. There are certainly states that do have exclusions, but for the vast majority of my patients who do move forward with me, we found that it's not a difficult process, particularly if you're coming from California and several other states throughout the United States that do have specific coverage for gender confirmation surgery. So once we do have a date established, I will need to see you in person, so one more time at a preoperative visit. So I do have many patients where the first time I do see you is at the preoperative visit because the initial consultation was a phone consultation. And this is a case for a lot of my patients that do come from far away, which is perfectly fine. But once again, at the preoperative visit, this will be an opportunity to review everything about the operation and all the post-operative care. Throughout this process, you'll have many encounters with the rest of my staff and then also the nurses in my office as well to ensure that all of your questions are appropriately answered. At the preoperative visit, I'll do a physical exam to see how the hair removal is going or has gone. And then we'll get your consent or permission to be able to move forward with the operation. We'll also provide you your prescriptions for your medication so you can get those filled beforehand and have them available after the operation. On the day of the operation, you'll show up to the hospital or the surgical facility, usually about 2 hours or so before the operation starts. You'll meet the staff, the nurses, the anesthesiologist, everyone who's going to be taking care of you. And then you'll see me usually about 30 minutes or so before your operation starts. At that point, we'll talk again. I'll answer whatever questions you happen to have. And certainly throughout this entire process, I think that it's really important for you to keep in mind is that if you do have questions, you can always reach out to me, my office, and my staff. So the operation itself for a one-stage penile inversion vaginoplasty typically takes me 4 hours on average to do. So if we have the operation starting, for example, at 7:30 in the morning, with the operation, with the setup, with the anesthesia time, typically will be done somewhere around noon. So one-stage penile inversion vaginoplasty involves multiple components. The very first step is called an orchiectomy. So this is removing the testicles. This is a very important aspect of the operation because it removes testosterone from your system, which you don't need. And then you'll also find that your hormone requirements will start to go down and that the use of blockers such as spironolactone won't be needed anymore because you've obviously had permanent testosterone removal with the orchiectomy. One thing that I do want to keep in mind is that with the estrogen usage, that for majority of my patients, I do allow you to maintain the use of estradiol before the operation and then immediately post-operatively. I found that being off of estradiol can oftentimes lead to a lot of mental distress, depression, and anxiety that can oftentimes affect, I think, the post-operative care of patients. So for the majority of my patients, unless there are other medical reasons, you can stay on your estradiol. But moving back to the operation, the other component of the operation is what's called a urethroplasty, but basically remaking your urethra. So the urethra is the tube through which urine travels and exiting the body. So what I do is I shorten it and put it lower down on your pelvis so that when you urinate, the urine goes down into the toilet, so creating a more feminine way of urinating. The other aspect of the operation is creating a clitoris. So a clitoris is important. The priorities of the operation are number one, to create a functional vagina, so having erogenous sensation, being able to engage in sexual intercourse, and then also from an aesthetic standpoint, to have a vagina that looks like a vagina. So once again, with the clitoris, I use tissue from the tip of the penis. I make sure the nerve and the blood vessel are still attached. I create a clitoris, and I place it in the correct anatomic location on your pelvis. For the majority of patients, you're able to achieve an orgasm usually around 3 months post-operatively, but for some patients it can take up until about 1 year. So everyone's going to be different. The other aspect of the operation is creating the vaginal canal itself. So I open up a space in your pelvis that's in the same anatomic location as for a non-transgender woman. I use skin from the shaft to line the opening and a couple inches into it. And then I use skin from the scrotum to line the deeper parts. So that's why it's important to have hair removed so that you don't end up with hair growing inside the vagina. I would say that in somewhere around 5 to 10% of patients, we do need to use additional skin because there's not enough genitalia tissue to work with. If that's the case, then we'll typically take skin from the groin crease. So that's that crease in between your thigh and your abdomen. Or for some patients, if they have excess skin, we can take it from the lower aspect of the abdomen. So in many respects, it'll be a tummy tuck type incision. But once again, majority of patients, we typically have enough tissue to work with from the shaft skin and then from the scrotal skin. And certainly during our consultation and during our preoperative visit, I can give you better information in terms of whether or not that will be something that we'll need to do. The other aspect of the operation that we'll also focus on is ensuring that you've had appropriate hair removal. So even in the best case scenario, if you've had electrolysis or laser hair removal, you might have a few hair follicles that are left on the scrotal or scrotum skin. If there are, then we remove them. So we use a Bovie electrocautery pen to zap those extra hair follicles. This is oftentimes, at least in the past, been referred to as follicle scraping. But for all intents and purposes, it's more like follicle burning, because once again, we do use a high-powered electrocautery pen to remove those excess hair follicles. If you have not done hair removal before the operation, it is not a contraindication to moving forward, and we'll do our best to certainly remove those hair follicles at the time of the operation. But it is definitely much more efficient, and you'll have a much lower chance of having hair growing in the vagina if you've effectively had hair removal before the operation. So I can't emphasize how important that is to do beforehand. There are certainly exceptions. There's some patients who may not be able to move forward with hair removal either because of the cost or either because of the physical or the mental distress. But certainly, if you can move forward with the hair removal, it is highly recommended, and you will have a much better outcome if you do the hair removal beforehand. The other part of the operation that I focus on is creating or recreating the vulva. So the vulva is the external aspects of the vagina. So I make the labia minora, which is the small inner lips, the labia majora, which is the larger outer lips, and then the clitoral hood. At the conclusion of the case, I place a catheter that goes into your bladder. I place gauze or packing that goes into the vagina, and then I place a large bolster, basically made up of gauze and non-adherent dressings, over the entire vagina. And then I place several stitches or sutures to tie this bolster over the area. So you have direct, constant pressure on the surgical site. And this is very important in swelling and to ensure that you're going to have a good outcome. So you'll be in the hospital or the rehab facility typically for about 3 days after the operation. So we'll check on you every day. So typically my physician assistant will come by every day, or another member of my staff, to check on you and make sure that you're doing well. The facilities and the hospitals at which I work have had lots of experience taking care of my patients, so you'll be in good hands. By the 3rd day, if your pain's okay, you're walking around, you're tolerating a diet, there's no evidence of bleeding, then it's okay for you to leave. I think what you have to keep in mind, however, is that you do need to stay in the Bay Area, the San Francisco Bay Area, where my office is. So for all of my patients who are from out of town, we do want to plan for a chunk of about 3 months being in San Francisco. That time period includes the day of the operation, the 3 days of recovery in the hospital or in the recovery rehabilitation facility, and then the 3 post-operative visits after that, which are typically 1 week apart. So once you've left, once again, the hospital or the rehabilitation facility at 3 days, then you'll stay somewhere in the San Francisco area, so hotel, Airbnb. If you have family that's here, you can certainly stay with them. And then you'll be there for maybe 4 or 5 days. And then you'll come back to my clinic in San Francisco, and that's when we have the big unveiling. So your first post-operative visit is going to be anywhere from 7 to perhaps even up to 10 days after the original operation. At that point, we'll remove the packing out of the vagina. We'll remove the big piece of gauze that's over the vagina, so you'll get to see it for the first time. And we'll remove the catheter and make sure that you're able to urinate. One thing to keep in mind is that we don't want you to develop any type of what's referred to as urinary retention, where you're not able to urinate or pee. So before you leave the clinic at your first post-operative visit, we do want to make sure that you're able to urinate okay. And about 10% of patients Urination is not possible, so we may have to put the Foley catheter back in place until your next post-operative visit. And this is usually due to the fact that there's a lot of swelling around the sphincter, or the muscle that controls the bladder, which makes it difficult for you to urinate. So once again, in about 10% of patients, we may have to put in the catheter for another week. The other aspect of the post-operative visit is really to get you familiar with the vagina and to get you familiar with dilation. So we do provide those dilators. So you do need to dilate 3 times a day, 30 minutes each time for the first 3 months. It's super important. The first 3 months are going to be the most critical. So 3 times a day, 30 minutes each time, and then as you go over the course of the year, you'll actually decrease the frequency of your dilation. So by the time you get to about 1 year post-op, you'll be dilating, I would say maybe once or twice a week. If you're engaging in penetrating sexual intercourse and you're doing that at least once or twice a week, that can count as dilation. Penetrating sexual intercourse you can start engaging in at about 3 months post-operatively, but a lot of women actually like to wait a little bit longer until they feel completely comfortable. So anywhere from 3 months to 1 year is when patients may start to engage in penetrating sexual intercourse if they are sexually active. Masturbation, you can start doing it about 1 month post-operatively, but once again, you do want to wait until you feel completely comfortable before moving forward with self-stimulation. I tell many of my patients I think it's important to start off with self-stimulation and feeling comfortable with your new vagina and with your new anatomy before moving forward with any type of sexual activity with another individual. Wound care is going to be super, super important. So for the first 3 months, you're going to have a lot of drainage coming from the vagina, and it's variable from patient to patient. But I would say that most of the drainage typically stops at about 3 months post-operatively, so you do have to use a lot of maxi pads, change them every few hours to make sure the area still stays dry. There's going to be a lot of swelling. The swelling will persist, up to about 1 year. I would say that about 50% of the swelling goes away at about 6 weeks. 80% of the swelling is gone by about 3 months. And then you have this lingering 20% of swelling that'll stay until about 1 year post-operatively. Pain is always going to be a concern for all patients. I mean, this is obviously a very sensitive area, but we do everything that we can to make sure that you're going to be comfortable. And we certainly don't have you leaving the hospital until we know that you're completely comfortable. So there's a whole variety of pain medications that we use to make sure that you're comfortable. Both opioid medications, such as morphine and Percocet, and then non-opioid medications that we use as well, such as Toradol or ibuprofen or Tylenol. But while I'm taking care of you in the post-operative period, we assess you on a frequent basis to see how you're doing and adjust your pain management regimen appropriately to make sure that we're taking care of you with the fewest number of side effects possible. Working and going back to school is something that you do have to keep in mind, because you will have to take off, you will have to take off time in order to appropriately recover. I would say that the vast majority of patients need at least 6 weeks of recovery before they feel ready to get back into the swing of things of life. And it's not just the physical aspects of it, but it's also the mental aspects of it. So from the physical aspects, you can understand that it's going to be very difficult to sit on this area for extended periods of time. It's going to be swollen. You do need to focus on dilation. It may be painful and uncomfortable. And then from the mental aspects, you will be tired. It does take a lot of energy. Your body's focusing on wound healing. And so you're going to find that it's going to be very, very difficult to focus on a full-time basis on your work or school endeavors while you're healing. So once again, typically at about 6 weeks, for some patients maybe even up to 8 weeks before you feel ready to get back to school or work. And we'll certainly do whatever we can to establish the appropriate paperwork that's needed to make sure that you do have that time off to safely recover. Other things that we do want to keep in mind post-operatively, as I was touching upon before, is kind of the changes from a mental standpoint. So there are going to be ups and downs. That's going to be expected. It's a big operation. It's an important operation. It's going to have effects on you on many levels. Ultimately, you will be happy, but it's going to be a process, okay? And so there might be some degree of post-operative depression. So it's important to reach out to your support system, to reach out to your therapist, to reach out to me, to reach out to my office, so that we can get you through this process. So if you do have a history of depression or anxiety or other psychological or mental issues, sometimes they can resurface after this operation. So you do want to be mindful of that, and you really do want to seek out help if you do develop negative feelings post-operatively. For the vast majority of patients, typically lasts for a couple days, maybe even a couple weeks, but I have had a small handful of patients where sometimes those post-operative blues can persist beyond 6 months to 1 year. Typically rare, but that's something that you definitely want to keep in mind, and also always reach out to your therapist, in particular if a lot of these post-operative depressive or negative mental symptoms persist for a long time. The other aspect of dilation that I wanted to touch upon is that you do want to listen to your body, right? So everyone is going to progress and heal at a different rate. So regardless, dilation is going to be your number one priority after the operation. So you do want to make sure that you have an appropriate, safe environment where you can dilate regularly and that you'll be able to commit to the time that's required for dilation. And once again, just to reemphasize, the first 3 months you're going to be dilating 3 times a day, 30 minutes each time. There are 4 dilators in the set, so based on your own comfort level, you can certainly advance up in the size of the dilator. Majority of patients typically are not using the larger dilator until somewhere between 6 months to 9 months after the operation. So what's important to keep in mind at this point is what are the potential risks and complications of a vaginoplasty? And so as I said, I spend a good amount of time reviewing your medical history and your psychological and social history because I want to make sure there's nothing in your history that's going to contribute to poor negative outcomes. But with that being said, what are the risks? So let's start off with the risks or potential complications that are rare. So one of them would be deep vein thromboses or pulmonary emboli. These are blood clots that develop in your legs or other parts of your body that then travel to your heart and lungs and can lead to problems with bleeding and can lead to problems with your heart. Very, very, very rare. I'd probably say less than 0.1% chance of that happening. And the way that we ward this off or keep it from happening is to get you out of bed and move it around, typically 1 day after the operation. You also have what are called sequential compression devices, which are devices that are placed on your calves and they squeeze the legs, and this prevents the development of these blood clots, but once again, very rare. There's a risk of having complete numbness of the entire vagina. Once again, very rare. I haven't had this happen, where there's no sensation whatsoever. This can happen with any surgical procedure. And what can be expected is temporary numbness, where after the operation, there are patches of vagina or even the entire vagina which may seem numb, and then over time that sensation does start to come back. For the majority of patients, I would say about 3 months is when the sensation comes back, but for many patients it can take up until about a year. Other risks or potential complications that are rare include the development of a rectovaginal fistula. This is where you get a hole that connects the rectum to the vagina. And in many cases, we don't know why this develops, but what happens is stool or feces travels into the rectum, through that hole in that rectum, into the vagina, and now out through the vagina. So you essentially have stool that is traveling out of the vagina, which is certainly not something that we want. Once again, relatively rare. I would say that it's less than 0.5%. And if this does happen, this does require surgical correction. Another rare complication is a complete closure or stenosis of the vagina. And this will happen in patients who stop dilating completely, typically. Once again, relatively rare for someone who is following our appropriate protocol. But if this does happen, this requires surgical correction, which can be quite difficult. So that's why we want to ensure that you're able to dilate and follow the protocol before moving forward with a vaginoplasty so that you do not end up with complete closure of the vagina. So trying to recreate a vagina after it's closed is not only technically difficult, but there's a higher chance of complications, higher chance of damage to the urethra, the bladder, higher chance of damage to the rectum, leading to a rectovaginal fistula. So that's why we have to make every effort to ensure that you're not going to develop this type of complication, which can be very, very difficult to treat later down the line. So what are more common things that can happen in the postoperative period? So discharge, as I said, having a lot of vaginal discharge. I think this is more of a given than an actual complication, but you do want to keep that in mind. Swelling, as I said, can last for a long time. In some patients, longer than others, so you do want to be patient with that. Changes in sensation, once again, going to be expected. You'll have areas of numbness, and in some cases, you might even have what's referred to as hypersensitivity or some degree of neuropathy or neuropraxia. So this basically means that you have hyperactive nerves. So for some patients, the clitoris can be super sensitive and hypersensitive. This can start happening a couple weeks after the operation and can persist up until about 1 year postoperatively. For the majority of patients, this is mild. But for some patients where it does become severe, there are certain medications that we can use to quiet down that inflammation and quiet down those nerves so that it won't be so much of an issue. There is a chance for developing what's referred to as granulation tissue. So granulation tissue is this type of beefy red scar tissue. It's made up of blood vessels and collagen that love to form in areas where there's a lot of moisture, where there's a lot of friction, which happens to be the vagina. So I would say that in somewhere between 25 to 30% of patients, you will develop this granulation tissue. And this is easily treated with topical medications to keep it under control. In the long run, granulation will go away on its own, but we do want to get it under control because it can impair appropriate dilation and penetration. It can make it painful. It can lead to bleeding. So we do want to make sure that this is something that is kept under control to prevent these issues from developing. Another issue that can develop, which happens in some patients, is tightness of the vagina. So you're dilating, following the protocol exactly, but you're still developing tightening of the vagina. And this can happen in some patients more than others. And for whatever reason, sometimes the skin in the vagina becomes really tough and really hard. Other patients, it remains soft and pliable throughout the entire course. But if you do develop this tightening of the vagina, the best thing to do is to increase the frequency of your dilation and also the duration of your dilation. So if you're dilating 2 times a day, increase it to 3 times a day. If you've been dilating only 30 minutes each time, increase it to 45 minutes each time. But we'll certainly walk you through this process. And an important thing to keep in mind is that throughout the entire postoperative course, we'll always keep a close eye on you. So for the first 3 weeks, you'll be here in the San Francisco Bay Area, and we'll have follow-up visits 1 week apart for the course of 3 weeks. And by the third visit, if everything is going well, then you can certainly go back home. And then we'll maintain follow-up visits with myself as well as with my staff every 2 to 3 months for the course of the year. And if there are any problems, any concerns, you can always reach out to us by email, by phone call, whatever is best for you to make sure that you're doing well, because we want to make sure that if problems do develop, we can address them early on so that they won't be too difficult later down the line. So in terms of other aspects of complications or issues, wound breakdown or skin breakdown, it's not unusual to have some degree of a wound necrosis, particularly in the lower part of the vagina around the opening. And the reason why is because this is an area where there's a lot of tension. There's also a lot of friction. There's a high bacterial count. Your dilator is rubbing against this area. So that leads, in many cases, to wound breakdown and skin breakdown. And this happens probably in about 100% of cases to a varying degree. So I don't want you to be surprised by that. And usually this starts to show up at about 2 weeks post-operatively. So you start seeing, yellowish skin, some skin breakdown. The incisions may open up a little bit. This is nothing to really be frightened about because it will heal. And it usually takes a couple weeks. If it's more significant, it might take a couple months. But once again, keep checking in with me and my staff, and we'll provide you appropriate reassurance and guidance in terms of what type of wound care you need when this does develop. Other risks include urinary tract infections. There's about a 10% chance of developing a urine post-operatively. We do keep you on antibiotics around the time of the operation and post-operatively to ward off urinary tract infections, but once again, you will have a higher chance of developing urinary tract infections now that you do have a vagina, because the urethra is smaller, so your rate is shorter, so that does increase your chance of developing a urinary tract infection. So having good hygiene, remembering to wipe from front to back is going to be important, and keeping the area dry is going to be very important. Other issues and other complications that can potentially develop are infections, so the development of a cellulitis. So this presents with burning, with redness. This is typically treated with antibiotics that you take by mouth. Probably about a 5% chance of this developing. There's also the chance of developing what's called a yeast infection, and this happens in maybe about 5% of patients. So burning, redness, bumps. The way of preventing yeast infections is by keeping the area dry, avoiding tight synthetic fibers and clothing like spandex. And once again, very good hygiene is going to be important to prevent that. There's also the development potentially of vaginosis, so having some type of vaginal infection or inflammation within the vagina. Once again, probably about 5, maybe 10% chance of that happening. So this presents with discharge, with a bad smell. If this is the case, can typically be treated with topical or local antibiotics to keep that under control. But once again, good hygiene is going to be very important. A very, very large or big consideration to keep in mind is the need for revisions. So about 30% of patients do move forward with revisions or touch-up procedures for their vaginoplasty. So I do everything in my power as your surgeon to ensure that you're going to have the best outcome possible. I will not leave the operating room until I know that I'm happy with the appearance of the vagina and the functionality of your vagina. But there's always going to be some degree of wound healing issues and also unpredictability in wound healing. As I was saying before, some patients heal beautifully, no issues at all, and other patients don't. They develop scar tissue. Or the labia minora don't stay the way that we want them to, and they flatten over time. Or the clitoral hood will recess, meaning that it'll go back, exposing more of the clitoris, which is not aesthetically appealing. Or there could be the development of scar tissue around the opening of the vagina, which makes penetration difficult. Or there can be scar tissue on the outside aspects along the labia majora that are unsightly or don't heal very well. One thing to keep in mind is that scarring, for the most part, tends to stay minimal on the external aspects or the vulva of the vagina. Any part of your body that happens to have very thin skin, such as a vagina or a vulva, tends to heal very well. It has a lower chance for hypertrophic scars or keloids. But it is important to know if you do have a history of scarring so that we can keep a close eye on you post-operatively. But with that being said, typically at about 6 months post-operatively, we'll have a good idea of what your vagina will look like in the long run. I would say that about 6 months, you are about 50% away, 50% in the way of healing. So you're still going to have, another 6 months for full healing. But once again, at 6 months, we'll have a very close idea to what the final vagina is going to look at. At that point, if there are aspects of your vagina that you're not happy with, so once again, the labia minora are not as robust as you want them to be, there's not a nice division between the labia minora, the majora, you feel like there's excess skin in the labia majora, you don't have an appropriate clitoral hood, there's scar tissue, then those are all things that we can address at the revision. And so we would typically schedule that at about 9 months to 1 year post-op. So the revision is typically done as an outpatient procedure, meaning that you don't have to stay in the hospital. The revisions are usually 1 hour, maybe 2 hours, and then afterwards you'll be in the recovery room for a little bit, and then you'll be able to go home, and then we'll check up with you in a couple days. But you do want to give yourself a couple weeks, anywhere between 2 to 4 weeks to heal from that. So once again, that's something to keep in mind, that there is always a potential for a revision. And I don't want you to think that that's a failure on anyone's part. That's not a failure on my part as a surgeon, or a failure certainly on your part as a patient. It's just that there's, even in the best case scenario, there's always going to be some degree of unpredictability in wound healing. So we do want to account for that. And as I said, you're always going to be checking in with me. If there are any issues, bring them up. I want you to be open and honest, and that's going to be important to allow you to have the best outcome possible. What you want to keep in mind is that the operation in and of itself is the easy part. That 4 to 5 hours in the operating room is the easy part. It's that post-operative recovery that can take a long time, that can take up until about a year. So the transition is not with the operation. The transition occurs with the operation and then with your year-long post-operative recovery. So it's really important to keep in your mind that it will take a year before you have your final result for your vaginoplasty. It's not an instantaneous occurrence. It's something that definitely will take time. And just know that I'll always be there for you. My staff will always be there for you. So always keep checking in with us so that we can ensure that you have the best experience and the best result possible. Thank you.